Rahim. So I am in between the lunch break and the presentation, so I will not take much time. I have a 25 slides only. So, so today my topic is role of PET-CT in breast cancer. So these are my affiliations. I have no conflict of interest to disclose. So I will start. Can I have, you have a pointer, please? Yeah, it's working. Thank you. So I start with a case. This is a case of 39-year-old young lady with left breast cancer, ER/PR positive, and this is a whole body bone scan. Didn't find anything. The size of the tumor is 1.5 centimeter. So what do you think? What will be the mode of further treatment this patient? Young patient, 1.5 centimeter breast mass with a dense breast. Likely this patient will go for a surgery. But having a young patient with dense breast, PET scan was done. Can anybody guess what type of PET scan it is? Yes, no. This is a FAPI scan, fibroblast activated protein scan, and you can see that one. This patient has a very extensive mass with level 1 and level 1 to level 2 lymph node with internal memory involvement, plus patient has a liver involvement and multiple bony lesion, and additionally there is a adrenal lesion as well. So totally changed. This patient becomes stage 4 and go for a palliative chemotherapy. Another case. This is a 64-year-old female recently diagnosed with a breast cancer, locally advanced breast cancer, so underwent a FDG PET-CT. So if you can see that one, this patient has some very heterogeneous uptake in the breast, and there is a small prominent left axillary lymph node, equivocal, and you can see the difference between this FAPI. FAPI has a very extensive tumor, and plus patient has a axillary lymph node metastasis plus the supraclavicular. So it changed the management by seeing the different one. So this is my outline. I've talked about the breast cancer introduction. I will talk about the different tracers, and then finally. So breast cancer is the most common malignancy in women and a leading cause of death. It is approximately 2.3 million cases each year diagnosed with the breast cancer. And Pakistan has one of the highest incidence of breast cancer in Asia. Around 90,000 women are diagnosed with breast cancer each year, and half will be died with it. So what is the role of nuclear medicine? The breast scan imaging has transformed the way we detect, characterize, and monitor breast cancer, enabling more precise and personalized care. So breast cancer is a very heterogeneous tumor. So we have a different histological type like ductal, lobular, and there are multiple subtypes like luminal A, luminal B, triple negative, and they have a different prognosis. Patient with a triple negative, they have a more worse prognosis, and as compared to the one with a luminal A, which having a good prognosis. Like talk about the conventional, they are equally good, and they make a foundation of breast cancer imaging like mammography, ultrasonography, and MRI. They are meant for diagnosis, detection, and staging, and each modality offer a unique and complementary diagnostic strength. So molecular breast imaging provide you the functional assessment of the breast cancer by visualizing the metabolic molecular characteristics of tumor beyond the conventional anatomy. So there are different radiotracers available for doing a breast cancer imaging. There are some conventional tracer like FDG. Then we do a bone imaging with technetium, and there is a PET tracer called sodium fluoride for bone imaging. And there are the upcoming tracer. These are the investigational tracer. The top three are FAPI, FES, and trevahexane. So number one is an FDG. The another one is the fluoroestradiol receptors. So you will image the receptors, estradiol receptors. And then we have a tracer which target the fibroblastic FAP, okay, the fibroblast activating proteins. And then you have some miscellaneous tracer like trevehexane or targeted some certain receptors like trastuzumab. So they have a spectrum of tracer available for breast cancer imaging. So I will start one by one and look at it, what have their advantages and some limitations. So as you know that FDG is a glucose analog, and its uptake is facilitated by the GLUT receptors, and it is trapped inside the cells. As Dr. Amna told you before that one, the FDG uptake is related to the proliferative activity and the aggressiveness of the tumor. But the sensitivity of FDG is depend on the various types of the breast cancer, receptor status, grade, and some tumors, some types of breast cancer having a high avidity and some having a low avidity. So sensitivity varies with the different type of breast cancer. So still FDG make a vital role in the staging of breast cancer, from staging and restaging. So what are the common indications for FDG PET CT in breast cancer? Is for initial staging. It is very good in the lymph node assessment rather than the primary staging. Primary staging is mainly done by ultrasonography, mammography, and MRI. But in the young patient and a locally advanced disease that we have more chances to develop a distant metastasis, they have a very good role. And for evaluation of distant metastasis, so main indication is evaluation of distant metastasis and prognostic prediction. And FDG is a prognostic marker. If it is highly avid, having a poor prognosis. And last but not least, the very important is the evaluation of treatment response, either in a neoadjuvant setting or from start. So FDG uptake is vary with the tumor type. So we have a certain tumor of lobular breast cancer having a low uptake, and as compared to the triple negative with having a higher uptake. And you see a little bit moderate uptake seen in the patient with ER/PR positive as compared to the ER/PR negative. So lobular having a low uptake and triple negative having a higher uptake. So sensitivity of FDG PET CT is lower in the lobular breast cancer. Why it is? Because it has a lower XUV max, because it is having a lower tumor cell density, decreased proliferation rate, and you have a diffuse infiltration of the tumor of the lobular breast cancer and a low level of GLUT expressions. The second tracer is the FES. This is the second tracer which is approved by FDA for breast cancer imaging. What is the fluoroestradiol? It targets the ER receptors. So it gives you an in vivo imaging of the ER receptors. So it is very good for the with the patient with ER. So it was FDA approved for the metastatic breast cancer. You cannot biopsy in each and every lesion whether this patient came with the recurrence of breast cancer. Doesn't mean that one it was ER/PR positive before, and even in the recurrence it is having a same biology characteristics. So having a very good impact to assessing the ER/PR expression in the breast cancer. It very helpful in the invasive lobular cancer. Why? Because 95% of lobular breast cancer having a ER expression, and they are very less avid on FDG, and having a high specificity. As you know that the FDG is not a specific marker. It go to the infection, inflammatory condition, and other benign condition having an uptake. But as compared to FES having a higher specificity because they are not positive on mainly on infection and inflammatory conditions. And it will be very helpful, this tracer, for the majority of patients. If the patient has a luminal A or ER/PR positive, they underwent for a hormonal therapy or endocrine therapy. So FES having a very good role in assessment of the patient on the endocrine therapies. And sometimes these hormonal therapies was given in combination with other targeted therapies like riboseclib and cyclin dependent dekinase. So you want to know that one, this one will help by adding this CDK with for either hormonal therapy addition will be benefit or not. So I will give you an example. This is a case of 54-year-old female with newly diagnosed breast cancer. The upper part imaging of the FDG PET CT, and FDG PET CT is positive, having an uptake in the breast mass. There is a prominent lymph node which is non-FDG avid. As compared, you can see that one, the FES having not only positive in the breast tumor, but it is also positive in the axillary lymph node, and the biopsy came out to be this patient was positive with the lymph node metastasis. The third very promising tracer is the fibroblastic activated protein, FAPI. It is a type 2 transmembrane glycoprotein. It is expressed in the fibroblasts such as the cancer associated fibroblasts, which is form the main component of tumor stroma. And this FAP expression is seen in the 90% of epithelial tumors. And FAPI target the tumor stroma, providing a high uptake, high tumor to background ratio, and enhance the image clarity, enables the precise tumor staging and characterization of these tumors. So this is an example of tumor microenvironment. It's a very good diagram understanding of the what is the tumor environment. This white is the tumor cells, and this spindle shapes is the cancer associated fibroblast. So FDG target the tumor cells and by having a high mitochondrial activity, but fibroblast, the FAPI target this cancer associated fibroblast. And good thing is that it is having a good uptake regardless of tumor grade. Its uptake is overall high uptake in both high and low grade tumors. So you can exploit that one doing a low metabolic active tumors doing a FAPI imaging. In lobular breast cancer is one of those tumors. So the question is, which modality is more effective in breast cancer, either FAPI or FDG? This is not a fair comparison. You are comparing oranges with mango, or this is a different, the way of looking at the tumor is different. One is looking at the tumor stroma, and one is looking at the glucose uptake in the tumor. So the target is different, looking at the thing is different. So in the aggressive tumor, FDG may be superior. In the low grade tumor which having a high fibroblast activity, FAPI will be good in it. Here is one example for my cancer center. This is a 65-year-old female with breast cancer, no spatial type. Then FDG is seen, and you can see that one, there is some heterogeneous uptake in the right breast mass. There is very minimal uptake in the right axillary. You will commonly see it in every patient you do an FDG for any tumor. As compared, you see this FAPI images, very extensive tumor, and it is infiltrating the skin as well, and you can see the extent of tumor is great, and having a axillary lymph node from level 1 to level 3, and additionally you see FAPI avid bony metastasis. If you go back and look at the imaging on FDG, you found there is subtle uptake in the bone marrow in the proximal left femur. So definitely the FAPI having a better characterization of the tumor in breast cancer. So what is the role of FAPI in the breast cancer? Is a high diagnostic accuracy, a high tumoral uptake, high tumor to background, and it will be alternative to the tumor like lobular breast cancer, which having a very low avidity in lobular breast cancer. it outperformed not only in a primary tumor and in the axillary lymph node. Axillary lymph node usually metastases show higher uptake on FAPI as compared to FDG, and it found additional foci. You will see the extent of the tumor in last case having a very big, so you will detect the additional foci and the multicentric disease as well. So totally things will change depending on the, if you have a localized tumor, they will go for a wide local excision. If you have a multicentric disease, they will go for a neoadjuvant chemotherapy. Another example, this is a case of 65-year-old female recently diagnosed with a invasive lobular cancer. So you will expected that one in invasive lobular cancer having a very heterogeneous, this is a locally advanced tumor, but doesn't show up any significant uptake. There are prominent lymph node, it can be inflammatory, it can be anything, but as compared to the FAPI images, you will see that was a locally advanced tumor. The extent of tumor is phenomenal with FAPI, and you found there is an additional foci in the left axillary lymph node, and biopsy came out to be positive for the lymph node metastasis, and patient become an N1 disease, go for a neoadjuvant chemotherapy. So, and additionally, FAPI is very good in detecting of the metastasis, especially the unusual metastatic size like gastric, peritoneal and ovarian metastasis. And one of the prominent detection of metastasis is peritoneal metastasis. Is very common in the invasive lobular cancer. Why the FAPI is very good in detecting of the peritoneal metastasis? Because they having a very high to tumor background activity, very high uptake in small peritoneal disease. So as we know that one FDG is not good at detecting the peritoneal metastasis, FAPI is very good in detecting the peritoneal metastasis, and FAPI is very good in detecting in non-FDG sclerotic metastasis. FDG is very good in lytic metastasis, but not good at in sclerotic metastasis. And these sclerotic metastasis is very common in invasive lobular breast cancers. Another case. So this is a case of patient with the lobular, known case of lobular breast cancer treated in 2019. Now just presented with a axillary lump. Is no definite mass is there. So to look at it, to go for a biopsy. So we underwent a FAPI scan. You can see the avidity of that tumor, the very intensely activity in axillary mass with a chest wall muscle invasion. Not the serratus anterior intercostal muscles is also involved. And did you notice anything else? There is an uptake which is not detected on the FDG, and this is the perinephric metastasis of lobular breast cancer. So this patient underwent a chemotherapy. You can see significant reduce in FAPI uptake in the axilla, and so still mild activity. They continue the chemotherapy. Chemotherapy is working at that point of time. There's no need to change. They continue the same chemotherapy. Now see the complete resolution of all the tumor. So the FAPI, then came the other tracers. These are the investigational tracers like travahexin. What is travahexin? It targets the alpha V beta 6 integrin receptors, and it is overexpressed in the very aggressive tumors. So it is a marker of aggressive malignancy. So what type of aggressive malignancy in breast cancer? Triple negative. So it will be a good prognostic marker, integrin. Second investigational tracer in you can see a lot of publication is coming is trastuzumab. What is trastuzumab? Herceptin. It is used for the breast cancer treatment. So did we image those Herceptins? Yes, we can target the human epidermal growth factor HER2 receptor to image these tumors. But still, these are the investigational tracers very small institutional based experience is there. There is no precise larger population randomized controlled trial is present. So, okay, so we have an FDG, we have an FES, both are FDG approved, FAPI very promising, and then we have some investigational tracers. So just my light slides just summarize the things. So FDG, it target the GLUT receptors. What are the pros and of FDG? Widely available, very good in initial staging and restaging of breast cancer, and it provides that prognostic. What is the cons of FDG? Have a low sensitivity, especially in the lobular breast cancer and certain low grade tumors of breast. There's a mucinous type of breast cancer having a low activity. And it is not good in the certain type of metastasis, non-FDG avid sclerotic metastasis. You will see around 15% of cases. Second in FES is target the FES receptor, estradiol receptors. What is the advantage? It is in vivo imaging. You cannot biopsy the each site of whether having the heterogeneity is very common in breast cancer. So it gives you an in vivo imaging of the ER expression, and it is very good in response assessment. You give this hormonal therapy for 5 years and they have a lot of side effects. So whether you propose that on whether these tumor having a ER/PR expression or not. So you want to know those ones. So it's very good. But there is some limitations, physiological uptake seen, and there's a lot of background activity seen. And there is some competitive, you are giving an hormonal therapy, you have to stop certain hormonal therapy for certain period of time, and especially sometimes 6 weeks as well. So other very promising traitor is the FAPI, which target the cancer associated fibroblast. It improves the diagnostic, having a high tumor to background and having a theranostic potential. You can treat those patients. You can label with the gallium, do an imaging. If it is positive, you can treat with the lutetium, FAPI, and these patients. And sometimes we have a very aggressive case. But last one. But it will affected by the biodistribution. There are false positive and inflammation and infection. Other investigated agents are very prominent. Travahexin, it target the integrin receptors and very good at and give you a prognostic significance. But still, these investigator traits are in the investigational stages. We don't have a good data to implement in the clinical practice. So, lastly, I will conclude that still FDG having play a vital role in management of breast cancer, especially for initial staging of locally advanced young patient and for the restaging and recurrence. And it gives you a vital potential for the responses, especially for the response of bone metastasis. FES again is a very good look at it, the ER/PR receptors important, so you can see the monitor the ER/PR expression, especially patient on endocrine therapy. FAPI is an alternative, especially with the tumor which are non-FDG avid. The example is lobular breast cancer. There are some my acknowledgement for my previous Kuwait and Oman, and thank you very much.